I can see Madam Suchitra Sudhir. Good evening, Madam Suchitra. I hope she's
Suchitra
around.
madam? Maybe she's just joined and
Just
she's
joined, and yeah, Dr. Kunjumadin also. So,
Good evening, madam.
yeah, good evening. Namaste. So, how are you? Please unmute yourself. Please unmute. Yeah.
Hello.
Yeah. Hi, madam. In fact, I
Hi.
wanted to call you and talk to you personally, but I said maybe I should not disturb you. Let me talk to you when you're on the program. So, thank you so much, madam, for accepting the invitation also, and thank you for collaborating with us. Thank you so much.
Thank you. Thanks a lot. It's my pleasure, actually.
So, I think last year we have had programs with K4G. All the societies we have clubbed, and we have had last year. So I'm planning to do that also with your leadership. And definitely, I'm looking forward. So, madam, I'm contesting for Foxy Vice President, and
Which zone,
from
madam?
West Zone.
West.
West Zone.
Okay.
Yeah.
Right.
Yeah. I was the breast committee chairperson, and I see governing council member also.
Okay.
So yeah. So
That's
basically,
nice.
thank you. Basically,
Basically,
I'm a
you're from.
private.
Where are you practicing from, madam?
I'm practicing in Maharashtra. That is close to Nagpur.
I see.
I'm
Exactly?
from Pune. Basically from Pune, but I'm settled at Yavatmal.
Yavatmal, I know.
Yeah. Hello, Dr. George. Yeah. Good evening. Good evening, everybody. Hello.
Hi, good evening.
Good evening. Good evening. So last year we have had 5-6 sessions almost, including all the societies, and Dr. Kunju Mohiddin, of course, he has cooperated well, and we have done all the sessions. So Dr. Shama and I think Atulya, both of them, they have coordinated the sessions.
So this year also we are planning to follow in his footsteps and have a good connection with Foxy. And wish you all the best, madam.
That will be. Thank you so much. Thank you, madam. So I was a Foxy Breast Committee chairperson, and because of that, mostly all the societies I'm in touch with. So 18 to 22, I was a chairperson. So breastfeeding, breast cancer awareness, all those things. And as ICOG chairperson, also I have done lots of programs. Because it's a focus academic body, no? So, and I too focus academician as well. So definitely looking forward for all your support and all of you to have great academic session. Yeah, Dr. Fesi is in flight, I think, Mumtaz. He said he will join little late.
Madam, you have come to Kerala? You have been to our place?
Yes. We have. I have come to Kerala at least 2-3 times earlier for the. I had come to Calicut for South Zone of Foxy.
Okay.
Yeah, and also to Kollam for AKCOG last year, last year. Yeah.
I see. You can also come to Kannur. We are in Kannur.
Yeah. Thank you so much, madam. Thank you for the, yeah. Now, I think Angamali and Kochi, they have invited me, March 10th, 9:30. So most probably I'll be joining them.
Nice.
I would love
We are
to,
in the
definitely.
we are at the northern end, madam.
Yeah, northern.
We
Yeah,
are northern end near Karnataka.
yeah. Okay, good. Tanu, is it the same for Shaijas?
Yes, Shaijas is in
Same
our
society.
society.
Yeah, yeah. He is
Everyone
in
knows
your
Shaijas, no,
society. Yeah.
because he is very
He's
talented.
in proxy, no? Yeah, and he's in communication with us.
Yeah.
I'll just call Dr. Kiran. Hello, Madam Vani.
Hello.
Good evening.
Hello. Namaste.
Namaste, Madam. Good evening.
Hello.
Dr. Sneha Buyar here from Maharashtra.
Yes, thank you. I worked in Manipal and St. John's and retired since 9 years. So I never miss the Zoom meeting so that we can keep. It is nice to listen to people and interact also.
Yeah.
Where did you study, Suchitra?
I studied in Calicut, madam. Calicut Medical
Okay.
College.
So I think Shai just studied in JIPMER many years after me.
You were in Pondicherry, madam?
Yes, 72 I joined MBBS in JIPMER
I see.
with my husband. He's an anesthetist.
Okay.
Okay, I just put my dear to say hi to both of you.
Thank you, madam. You seem very familiar. I don't know why.
No, maybe when I used to come to all Kerala meetings when Dr. Rajan used.
Probably.
So we used to keep doing
And,
panel discussions in Kottayam and Cochin.
and you look like a
Okay.
Keralite.
All the best. All the best. Yeah.
Yeah, 7:28, no? So I think Mumtaz, we can we start? So under your leadership, we will plan few academic sessions virtually, madam.
Okay, definitely.
So we will club four societies and we'll do the work.
I'll keep in touch with you, madam.
Whatever
Okay.
topic.
Mhm.
Thank you so much.
ಹೌದಾ
Hello, Dr. Mini. Good evening. Hello. Oh, I think her audio is not on also.
Hello. Hello, good evening.
Hello, good evening. Good evening, Dr. Rishi.
I am Dr. Joshi.
Shashna. Yes, good evening.
Hello, Reshma.
Hi, madam. Hi, Sneha, madam. Sujitra, madam. Unyamuddin sir is also joined. And Dr. Joshi and Hari Prasad sir. I'm audible, no, madam?
Definitely.
Yes.
Good evening, good evening.
Yeah, good evening, Dr. Reshma.
Good evening, sir.
Good evening, Dr. Sneha Buyar here.
Yeah, I know, madam. Very welcome to Perindalmanna. Happy to have joined us, Sujitra ma'am and Sneha ma'am.
So good evening all. I think without wasting much time, we'll start the webinar.
Yes.
This is the 17th monad from the Perindalmanna OG Society. And this time we have our own president to start the first session. Actually, this is the first monad after Madam has taken over as the president of Kerala Federation of OG Society. So very happy that you are with us today, Madam. And
Thank
Madam's
you.
area of interest, special interest, Madam is doing everything, but Madam's area of special interest is prevention of cancers and oncology management of different cancers. So today, Madam is going to talk to us about what we can do as gynec to prevent breast cancer. So because any patient, whenever she has a lump, probably the first person she meets or consults is a gynecologist, not a surgeon. So what we can do at that point of time, Madam will be explaining to us on that. So over to you, Madam. Can you share this screen, please?
1 second. I'm starting, huh?
Yes,
Start.
Madam.
Let me see.
We have two guests of honor today, but they have not joined. So
I have
when
joined.
they
I have
join,
joined.
we'll just introduce them.
I have joined, madam.
Dr. Mumtaz, Dr. Kiran Kurtakoti,
It's
President
okay.
of AMOX, has joined.
It's
So,
okay. Fine.
welcome, Dr. Kiran Kurtakoti.
Yeah. When Sneha calls, it is difficult for anybody to refuse. Thank you, Sneha, for that invite. And it's really
Thank
a
you.
pleasure for me to be here and sharing the dais with Fesi and everyone, respected Dr. Suchitra madam. And it's really, I look forward to listening to what you would be talking on, how to reduce the breast cancer prevalence. In fact, MOX will be launching a Pink Palm initiative. So the Pink Palm initiative is to educate the women about how to do the self breast examination. So really look forward to what you would be telling us on the same. And Dr. Sneha, you are really doing a great work as the committee chairperson of AMOX, as well as you've been a very fantastic worker for AMOX. So thank you. Please do continue with your activities, and I look forward to your panel also. Thank you so much. And again, my regards to everyone in KFOG, Kunji Moideen, and everyone, Dr. Paili sir, if whenever he is there. And thank you so much for inviting me to be the guest of honor for this talk. Thank you.
Thank you very much, sir.
Thank you so much, Dr. Kiran. And, your best wishes and of course your inputs definitely are always welcome. So thank you once again for gracing the occasion.
Shall I start?
Yes, Madam, please.
Okay. The slideshow is not coming actually.
It is there, Madam.
Oh, it's there. Okay.
Okay. It is small.
So good evening to all. And I really thank Dr. Mumtaz for inviting me for this session, because this is the first webinar after being, becoming the president of KFOG. And I'm very happy that Perindalmanna Society is hosting this, because it is a society very dear to me, especially because our immediate past president, Dr. Kunjumoideen, a person whom I admire and respect much, is the founder of this society. And Mumtaz is my dear friend. She is our Onco chairperson. And Reshma Sajan, who is also here, a writer beyond compare. All of them are very dear to me. So thank you so much. And actually, I chose this topic. I'm not an oncologist. I'm just an ordinary gynecologist obstetrician. But I have been involved in Malabar Cancer Care Society of Kannur, where we do a lot of screening. We go around doing a lot of awareness. Since 2017, actually, initially, we were more bothered about cervical cancer. So we used to think that cervical cancer is the most important thing. And after some time, we used to think that only Western ladies will get breast cancer, because we used to think they are sophisticated, they are professionals, they get married late, they have very few children, and even if they have children, they do not have time to breastfeed them, and they have sedentary jobs, so they become a bit plumpy, and they have more incidence of breast cancer, and this will never affect our women who are always running around. But now, breast cancer has become a very, very important part of our diseases. And especially Kerala. Kerala is the place where the maximum number of breast cancer is taking place in India. So actually, every 4 minutes, a woman is being diagnosed with breast cancer. Isn't it terrible? So actually, we as gynecologists are the first point of health contact for the women. Whenever they have any problem, they run to us. We are like their mothers. So we have to do something about this particular cancer, which can be prevented in some ways. So the WHO slogan for breast cancer is, no one should face breast cancer alone, because when a woman is diagnosed with breast cancer, she feels very upset because her femininity is being targeted and she feels isolated. There's a stigma around breast cancer. They feel they should not talk about it. They cannot be examined. I remember before, when we used to conduct breast cancer clinics, camps, hardly anybody used to come. But today, with a lot of awareness and things have changed. Women are coming forward to get checked. So we should be with the women, and no one should face breast cancer alone. And the Global Breast Cancer Initiative is aiming to decrease the breast cancer by at least 2.5% by 2040. So what can we gynecologists do about this? So that is something that I would like to share, because in this 2017 onwards, up to now, we have actually sensitized nearly 8.2 lakhs of women, public. We have camps, we go to panchayats, we involve the government machinery also, and the Kudumbasri, all the local women. And now, because people have started talking about it, suddenly it is no longer a terror. Everybody wants to know about it. People are talking about it, and that stigma is decreased a lot. And the lifetime risk of cancer in Indian women, breast cancer is the top. That is 1 out of 28 women may get breast cancer during a lifetime. That is why women are always afraid. Do I have that disease? They are so scared that they may contract this disease. So I have made a chart like this, A, B, C, D. That is, first of all, create an awareness. So what the mind does not know, the eye will not see. That's what we have been taught. So we have to sensitize the women and tell them, we have to be aware about the breast cancer, and we should teach them breast self-examination. Once a month, they have to do that. And clinical breast examination at least once in 3 years, even if they do not have any symptoms. And we have to diagnose it as early as possible and early treatment and follow-up. So this is the usual things. And awareness. How do we create an awareness? See, people will be sitting in our OPD outside in the waiting room for a long time. They will be sitting and dozing. Most of them will be looking at their mobiles nowadays. So best thing is to keep some pamphlets in the OP waiting area and hand it around. Let people read and find out. Especially Keralites are very fond of reading. So when they see something, they will read it. And they become aware. And secondly, we can have informative videos. We have some TVs in the waiting room, isn't it? So we can have some informative videos. This is breast. These are the symptoms. How can we prevent it? All that we can show in these videos. And classes. Occasionally, we ourselves can go and take classes, or we can train our staff, some of the nurses. If we are very busy, we can train some of the nurses so that they can take a class. They can get the women together. Even the men should hear about this because they are also involved. And of course, on special events like in October, the Breast Cancer Awareness Month, we can hold rallies and public events. Last year, we had a fantastic Pinkathon rally, which has gone into the Limca Book of Records because everybody joined it. It was a very fantastic program. So we have to make people aware of the risk factors for breast cancer. Naturally, it is mostly the female sex, but still, sometimes 1% chance of males contracting the disease. We have seen some males coming with lumps which have ultimately been shown to be cancer. And heredity. Actually, when I take class about breast cancer risk factors, when I talk about heredity, some of the mothers will come and tell me, Madam, don't say heredity. See, everybody knows we have had the disease. Our daughters will not get any suitors if they are told that this is a hereditary factor. But heredity is a factor. We cannot avoid it. So heredity does not mean that we have to tell them. It does not mean that they will definitely get cancer, but they have to be on their guard. We have to be always aware. This may happen to us. So they have to have screening. They can do gene testing. In fact, one of my relations who had breast cancer, her daughter tested positive for BRCA genes. So we have to make the children aware, make the ladies aware that these are the possibilities. We can prevent it. Prevention is better than cure. So that. Then very early menarche. Children nowadays, very early menarche. Some of them, even at 8 years, they are coming with puberty. And late menopause. Late menopause may also be triggered by hormonal use, feminine forever, things like that. And nulliparity. In Kerala, the fertility rate is going down. There's hardly 1.7 children. Fertility rate is at 1.7 per woman now. So when this fertility rate goes down, there is some increase in the breast cancer incidence also. That is a fact. We have to face it. So, and no breastfeeding. All professional women also busy. We cannot take leave. If we take leave, our jobs will go. So breastfeeding is put on the back burner. People want to immediately, they want to mix up some concoctions and give. So we have to tell the women, especially those who deliver in our places, tell them, you breastfeed your children at least for 2 years. You can prevent breast cancer. Isn't that a great thing? So, and of course, preventable factors for breast cancer. As I was saying earlier, we thought only Western women used to get this because they were having sedentary lifestyle, they were obese, they were eating very hamburgers and things like that. But now obesity has become very common amongst us, especially amongst the youngsters. All of them, we know so many young girls are coming with 100 kilo weights, 90 kilo weight. And they are all not able to decrease. It is easy to gain weight, but it's very difficult to lose weight. And as I said earlier, lack of breastfeeding. Nobody has the time. That bonding between mother and child is actually being lost because people are not breastfeeding. And hormone therapy. Hormone therapy, of course, for a short time, it is okay. But some people want to be feminine forever. They want some estrogens. They want to have their periods for a longer time. Things like that. And alcohol and smoking. Alcohol and smoking is becoming very, very, very common. And these For all cancers, alcohol and smoking are the villains behind the scenes, especially smoking. Almost 30% of the causes for cancer is smoking. And of course, sedentary lifestyle. We sit, sit, sit. We don't want to walk. If we want to go a short distance even, we will take some car and go. And nobody, even if we walk, sometimes when I walk to the market, some ladies will see me and ask me, Doctor, what happened to your car? Is it breakdown? Why you're walking like this? So walking has become an abnormal thing, whereas usually I remember my grandmother, she used to just take an umbrella and walk to the town, even when she was 80. So this walking habit, we should not give up. We should keep on having an active life. More, and according to the Japanese, every 15 minutes after computer work, they get up, they stretch, and they walk around and come back and sit. That little bit of movement will make a lot of difference, and we can advise our patients if they are working in offices. Mostly women are working in banks, offices, computer, IT. Let them get up after 15 minutes, just get up, stretch. And if anybody says, what's wrong with you? You say, my doctor told me to do that. Okay, so these are the preventable factors which we can tell the people about. And of course, in India, there is a higher prevalence in younger women, and mortality rate is much more in India compared to Western countries. Actually, 50% of the breast cancers on the whole can occur after 65 years of age. But in India, it is, targeting the younger women. And once they get it, it is more difficult to treat. So challenges of breast cancer control in India, that is, first of all, the social stigma and embarrassments surrounding breast cancer. Nobody wants to say that I've got this disease. Delayed diagnosis due to lack of awareness in the rural areas. Many of them don't know, but we are the breast cancer brigades going around telling everybody this is the disease, you can get cured completely if it is diagnosed early. So let us, each one of us, do that. A limited access to diagnostic and treatment facilities. I think especially in the northern part, there are big states where a lot of people who are living in the rural areas, they do not know about it, and there is no diagnostic and treatment facilities. And high attrition rates due to loss of follow-up and financial constraints. I remember one of my patients' parents, they came to me after she delivered and they were just talking to me. They said, Doctor, nowadays everybody is getting cancer. So we both have decided if we are diagnosed with cancer, we will not live after that. We will both commit suicide. I said, my God, don't say that. Cancer is curable. So this is the sort of advice. They say financially we will be defeated. So we cannot afford to treat. I said, you will never get cancer. Be active and be aware and check yourself every month. So that you won't become a victim of the disease. So A is awareness. B is breast self-examination. This should be taught to every woman who comes to our OP. Every woman can do it because there is no expense, there is no embarrassment, there is every woman can be enabled to do that. For this, we have to have the help of their husbands as well, because usually we tell them, you put a big mirror in the bathroom and once a month, have a checkup. I know all of you all know about this, but this checkup should be done at least 1 week after the periods, because immediately after the periods, the breast will be a bit lumpy. So after 1 week, just feel the breast, first inspection, and then of course, palpation in a clockwise manner. And during shower, just feel if you can feel any lumps. This breast self-examination is really a savior, because so many women have come back saying that I have got a small lump, doctor. We just see whether there's any problem with it. And we immediately, we do the follow-up. So 9 out of 10 will be benign, but that one we should not miss. So that is breast self-examination. And C is clinical breast examination, at least once in every 3 years. So here comes the free breast clinic. So I have had this in my OP for the past, I think, 5 years. I've just put up a small board saying that anyone who comes for consultation can have a free breast examination. Any of their relatives who are with them can also have a free breast examination. And they just have, so many of them nowadays, in the beginning they used to be hesitant, but nowadays they say, doctor, can you just see, I'm having a doubt. Or even if they don't have a doubt, they say, we just want to see that there is nothing. So we have a register. Now nearly 4 or 5 registers are completely filled, and we have the name, the age, their mobile number, contact number, and we conduct an examination like this because there is we see both the breast, then mark the exact location, the size of the lump, and if there is nothing,
Sujitra
there is
madam,
nothing.
sorry to intervene. Can you please try to make it full screen, madam? Full slide view. Tara, madam, Tara, there is one. Yeah, more to right. On the bottom line. Yeah. Some more to the right. There's
It's not going beyond this point,
it's
actually.
not moving, eh? Okay, fine.
No, not
Fine,
moving.
madam. It's okay, it's okay.
Okay. So all the details and whether they have any comorbidities like diabetes or anything, all that is noted. We put there. And then the further examinations, whatever is necessary, we note it over there. And if they have to be referred, they are referred to the that particular center. Then we have screening camps, regular screening camps in our areas going on. At diagnosis, the main factor is that even if they get a lump, some of them don't come because they are afraid. So in that case, we tell them about what to do next and we follow up the patient. So key factors influencing survival rates in India, late diagnosis. In India, breast cancers are often diagnosed at stages 3 or 4. So this reduces the chance of survival and the mortality is increased. And we don't have a nationwide screening program. It is too costly. So at least we can put in a word when we find a lump or some finding, we can put in a word at the ultrasound where the screening is done. Just give it at a reduced rate, please. I often ask for mammogram at reduced rate, ultrasound at reduced. When we regularly send to some centers, they will oblige. And if it is in our own hospital, of course, we can give it at half rate or whatever it is. So, and medical infrastructure in India is not as good as the Western, and awareness and education and all those superstitions about breast cancer, all that people are afraid that as soon as breast cancer is diagnosed, breast will be chopped off and things like that. So they hesitate to come forward, but we have to follow up. So breast cancer in India has a relatively low survival rate of 66%, whereas US has a remarkably high rate of 90 to 95%, and UK is nearly 80%. So diagnosis, of course, ultrasound we do in less than 40 years, mammogram more than 40 years, fine needle aspiration cytology, core biopsy, excision biopsy, as the case may be. So most of this we can do ourselves, ultrasound, all that, but still expert opinion will be always better. Then this is a small device. Actually, we had a WHO study with this device known as PUD, portable ultrasound device. And it was so useful, and it's just the size of a mobile. We can take it anywhere we want. And when we do the screening, we can actually get pictures which are almost as good as ultrasound or mammogram. But unfortunately, due to the PNDT Act, we were not supposed to use it widely. It was a closed study, and the study was presented in Geneva recently. So that is, I hope it will come into action here. And this is a very useful tool. So highest prevalence of breast cancer in India is unfortunately in my own home state. And I think it is in some part due to the detection, because people go and get checked up more than I think in other states. And in our state, Thiruvananthapuram, which is the capital, is also the capital of breast cancer in our state. That's 43.9 per 1 lakh. So that's very terrible. So all the gynecologists, we have nearly 2,000 and odd gynecologists, we can reach out to the people. If each one of us puts our mind to it, creates awareness, has a free breast clinic, and encourages women to do the checkup, definitely we can make a change. So even the stars get breast cancer. We all know about Angelina Jolie. She had the prediction that 85% chance of getting malignancy. So of course we know mastectomy, hysterectomy, everything she did. And Sonali Benre has now had treatment. She is completely recovered, we heard, from stage 4 with metastasis, but aggressively treated, and she is okay. And our dear Srividya was a Malayali actress who was very popular, very talented actress. Unfortunately, her treatment was very irregular regarding breast cancer, and ultimately she succumbed. So these are the 3 ways in which we can respond to breast cancer. First is just go ahead. Second is take the correct treatment and survive. Even Mumtaz, heroine of yesteryear, was found to be, has survived. So, and so A, B, C, D, E, early and expert treatment, follow up after a positive diagnosis. We have to follow up because, and we should know that many of them become very depressed, they become anxious, some even want to commit suicide. So we should, before, during, and after treatment, let us just give a call. Nothing will happen. Our staff can give a call and inquire about how they are being treated. What a touch of tender, loving care will go a long way in helping to heal these patients. So nobody knows what will happen tomorrow, and these are some of our survivors in our Malabar Cancer Care Society. They have a group called FOSS, Friends of Cancer Survivors. They have regular meetings, they have songs, they have games, they have yoga, all that. And sometimes I feel they are happier than us in some ways. So, dear friends, I appeal to each one of you, do your bit. Just a little bit of time and trouble, definitely we can make a change. Together we can. Okay. Thank you for the patient hearing and wish you all health and happiness. Thanks a lot.
Thank you, madam. You have inspired us, all of us here.
Everyone
Not
should do
only
it,
for the patient
every
care, for
gynec
our own
should do it.
care also. Thank you so much for that very inspirational, beautiful talk, madam. Very, very beautiful talk. Thank you. If anybody else would like to make any comments or ask madam any doubts, please unmute yourself and please ask. Dr. Kunjumoideen is here. Do you want to ask anything or ask madam anything? Jyoti madam was here.
Basically, not to add, I really congratulate Madam for that wonderful talk with strong plans for screening as well as the game plans to increase the awareness. As Madam said, it's actually more than awareness, a thought block is there, even for the educated people to come forward and get the screening done. So, see, more awareness and more screening camps, more dedicated camps in these special groups like the teachers, doctors, nurses. So, in these special groups, so you may get a better response rather than in a general common population. So that we'll have a data also in that particular groups or which groups it is more relevant, means more rampant or more incidents, prevalence, everything we'll get the details. Thank you, madam, for accepting the invitation from Perindalmanna Society.
Thank you. Kunjumoideen sir. Yes, you are my inspiration actually.
Simple talk. I'm Dr. Vani from Manipal. It was a very simple and clear talk. When we were supposed to be when we were studying, we had to do breast examination for patients, and here you included the patient's attendants also. So you did a very simple way of doing a simple examination, and it was very good message. It was really nice.
Thank you.
Because for pap smear, Dr. Rajaram used to insist when we were students that you have to pap smear. But in JIPMA OPD, 200 patients, we'll only be doing pap smear. Here, just you have to do breast examination for any lady who comes to you, and you include the patient party also. And then you keep a track of their number. A very simple strategy. I'm very impressed. Thank you.
Thank you. Thank you,
Yeah.
Dr. Vani.
Yeah, I would just make one comment, Madam. It was an excellent and very much simplified talk, I would say. Very, very useful for our gynecologists also. I would just share with you that as a chairperson of breast committee, for every CME or every talk, we used to give a message saying that it's, it is our privilege and we have to utilize this window of opportunity because all the women come to us for whatever may be their problems. And in addition to our routine examination, make it a habit to examine the breast of those women. If at all you notify any abnormality, investigate further and, to a diagnosis and refer appropriately and, time. If at all you don't find any abnormality, you teach self-breast examination to the lady so that, she will be breast aware. So I think that should be all. And you have done it wonderfully. Thank you, madam.
Thank you, Dr. Sneha.
Dr. Reshma, thank you once again, Sujitra madam. Dr. Reshma,
Yes.
yeah, please
yeah.
introduce Dr. Sneha and the panelist.
Yeah. Next is a very interesting, never-ending topic that discussions will go on till we leave. Discussion on near-miss case scenarios. I think even if we hear and hear again and again, we will get at least a minimum few points as a take-home. Actually, near-miss, we don't know who is a near-miss. It is even a physical and mental near-miss for obstetrician as well. And managing such cases depends on who we are, what experience we have, and where we are practicing, whether there are anyone along with us to help us. So all these matters. And so it will be a great experience with Dr. Sneha Bhuya for her discussions on near-miss case scenarios. And I think for introducing her, we need too much of time because there are too many awards in her honor. International MS Signature Award for Phenomenal Leadership. Very nice, madam, to hear all these things. Being a woman, it's also inspiring for us. Asia GCC Award, Dr. S.N. Malhotra Individual National Award, and Dr. Durusha Distinguished Community Service Award, and Champion Foxy Award, Anand Bhai Joshi State Award, and Logmat Healthcare Excellence Award, and too many awards. And what I noticed is mainly for community service. That is worth noticing. And too many talks, and we know why. And orations and moderated 100 panels. So we are looking forward to it. And 30 chapters and articles in national publications, and has been in so many national and international committees as a major force behind many committees. And she is our candidate for Vice President Foxy West Zone 2. That also I have to remind. So looking forward for your panel, madam. And also we have eminent panelists from throughout Kerala. When we have 14 districts, we have 8 panelists from 8 districts in Kerala. Starting from north, we have Dr. Shasna from Kasargod, and Dr. Hari Prasad from Kannur, and Dr. Noori Khalid from Wayanad, Dr. Smita Dikoth from Kozhikode, Dr. Hema Warrior, eminent gynecologist from Palakkad, Dr. Geeta AP, Thrissur, Dr. Joshi from Angamali, and Dr. Joy Irali from Kochi. So it is from North Kerala to Mid Kerala. So from we can hear from all of them, guided by you, led by you. So waiting for the enchanting panel. Thank you so much, ma'am.
Thank you so much. Thank you so much, Dr. Reshma, for that kind introduction. A very good evening to all of you. And at the outset, let me thank Madam Suchitra Sudhir, Dr. Kunjimuddin, Dr. Mumtaz for taking special efforts for organizing this academic session. And I thank the entire team Kerala. So may I request Madam Suchitra to stop sharing so that I can share the screen. Or maybe the host can allow me to share the screen. Hello, Dr. Mumtaz. Hello.
Yeah, it is done, madam. You can share.
No, I can see Dr. Suchitra's screen.
Yeah, you just try.
Once you start.
Yeah. Yeah.
now
Now,
क्या डाला है कहाँ पे
yes, I think you
ले
can
जा
see
रही
the
बारिश
screen. And now this is full screen, right? So a warm welcome to all the dear panelists, Dr. Geeta, Dr. Hema Warrior, Dr. Smitha, Dr. Hari Prasad, Dr. Sajna, Dr. Nuri, Dr. Joshi, and Dr. George. So friends, we are talking about near miss case scenarios. So I'm sure near miss is a terminology. Actually, this is borrowed from the airlines industry. And you can see the two aeroplanes overlapping each other, you know, they're crossing each other. So that picture depicts the gravity of the situation and the urgency of intervention it demands. So it is defined as the critically ill pregnant or recently delivered woman who had died otherwise had it not been the luck and the good care on her side. Of course, analysis and going through near miss cases will help us to assess the quality of health services and points to area of improvement and intervention. According to WHO, the severe acute maternal morbidity in India is almost 8.23, that is preventable. So we are all the time talking about maternal mortality rate, which was, 3 decades ago it was almost 500 plus. 2 decades ago, it was 300 plus, and last decade it was 100. And we are fortunate to have it, less than 100. Hearty congratulations to Kerala for having it 19 and Maharashtra 33. So, friends, it's not only rates and ratios, these are the women. They have their faces, and we obstetricians have seen them or witnessed them in the phases of their distress, despair, and agony. So these keep on haunting our dreams. That is how it is expressed by Dr. Mohammad Fatullah, the past president of FIGO. So without much ago, we would start with the panel discussion. Of course, the incidence of this kind of SAM or the maternal mortality is also on a rise. The near miss cases are becoming very, very common even in the apparently normal women, and the reason being the changing demography of the obstetric population. Every case is a new learning for us, so never stop learning, because life never stops teaching us. Life is the best teacher, and of course we have to be a good disciple. So with this, we start with the first case, and so we start with the first panelist. We have this second gravida who has had previous cesarean section, last childbirth 1.5 years back, and she comes to you with 7 days overdue. You do her pregnancy test, it is positive. She requests you for medical abortion. So the doctor prescribed the tablets and asked her to come for follow-up after 7 days. On 6th day, around 11 p.m., she was brought to the hospital by the relatives in a collapsed condition. On inquiry, she has not bled, only spotting and of course occasional giddiness. So Dr. Geeta, when you examined her, she's got tachycardia, her blood pressure is only 70 and pallor plus plus. So what is your differential diagnosis, and what investigations you would advise her, and how do you Dr. Geeta, please.
Good evening. Good evening. Am I audible?
Yes. Please go ahead.
Yeah. Thank you, the Peddalmana Society, for including me in this panel discussion. And good evening, Madam Sneha. Actually, this patient looks. The first question was the patient's UPT was positive, but did she get a scan done? I think not. There is nothing mentioned about a scan being done.
Right.
Yeah, she has not. She has requested a medical abortion, and she has been prescribed the medication for, and she has taken the medicine.
Yes.
So, I personally, we all, our this thing. My dictum is that before prescribing any medication,
Yeah, we'll come to it,
always.
madam. We'll come to it. We would just
Yeah.
discuss the what is the diagnosis and how
Yeah,
we
in this
manage
patient,
case
most
at the
likely,
infancy. Yeah.
most likely she has collapsed. It's an hemorrhagic. Somewhere she is bleeding, which obviously is not outside, so it must be an intraperitoneal bleed, and she
Correct.
must be having either a tubal ectopic, or it could even be a scar ectopic, which is bleeding from.
Right. Right.
So that's my. It's unlikely to be a abortion bleeding, which is causing the her state of
Yeah.
shock.
So what
So
investigations you would advise
investigation,
that one?
basically, I think because she's already come in a state of shock, the basic things that we need to know is probably her hemoglobin, her blood group, which that is not known, and ultrasound, if that is possible, yes. Otherwise, even without that, probably she needs to have an intervention done. If it is
Right.
possible to have an ultrasound, definitely, because you have
Right.
given the ultrasound report here as an adnexal mass with free fluid, then she
Yeah.
must be, the diagnosis is very clear.
And
She's having an
hemoglobin
ectopic,
was 7
ruptured
gram per
ectopic
cent that point
pregnancy.
of time. So how do you go ahead with the management?
Yeah, this patient, the things that need to be done is that we have need to counsel the patient on the possible and the bystander about the possible diagnosis of an ectopic pregnancy. It needs to be tackled immediately. Blood needs to be arranged, and the anesthetist needs to be informed, because she doesn't look in a fit state for. She's already in shock. Probably the best thing would be a laparotomy, but for a person who is, it may be possible even to do a laparoscopic surgery also.
Perfect. Perfect. So basically, you have to counsel the patient and relatives and prepare for, the operative procedure, whatever maybe you are comfortable with. So informed consent and consent for blood transfusion and aggressive resuscitation. You have to stabilize the patient before taking her to OT. And then, of course, so as you have rightly pointed out, it can be laparotomy, can be even laparoscopy, because expert laparoscopic surgeon would be comfortable and you can easily do that, whether you would go for salpingectomy or a conservative surgery.
This patient would need a salpingectomy.
Right, because it's a ruptured ectopic pregnancy, right? So basically, this patient needs an urgent intervention, right?
Yeah.
What are the now we come to whether this is now really almost a near miss. So it is such a simple condition, but then what are the lessons learned? What were the flaws in this case? What was missed initially? So if you can throw some light on that.
Yeah, that, like I mentioned before, whenever the patient approaches us for a medical abortion, or even when she comes with the vague symptoms in early pregnancy, or even if she is coming with a lower abdominal pain in early pregnancy, this patient obviously came for a medical abortion. It is a mandatory, I feel it is mandatory that we should have an ultrasound before prescribing any medication for medical abortion, because otherwise we'll be missing tubal pregnancy or an ectopic somewhere else.
Yeah, I think even when you are doing any MTP procedure, the basic investigation of hemoglobin, blood group, and of course the basic ultrasound should be done, because you want to rule out ectopic pregnancy. For such early pregnancy, you even by clinical examination, you may not be able to diagnose the ectopic pregnancy, and that is why, even though it is not mandatory by law, it is recommended for the safety of the patient and for yourself. I think that's a take-home message from this case. So thank you, Madam Geeta. We now move on to the second case. Here we have, a 36-year-old obese infantile woman who conceived after IUI. Her husband stays in Dubai and she stays in a village. But because this is a precious pregnancy, she came to, the hospital for regular prenatal checkup. And knowing that her target scan, her basic investigations are normal, she's lost to follow because she stays in a village. At 34 weeks, she reported to the primary healthcare center with the complaints of pain in upper abdomen and mild edema. When the doctor examined, the BP was 176 by 116. Fetal growth was apparently normal, but she had proteinuria. Her BP was high at PHN, that's why they started with tablet nifedipine retard. The patient was advised admission at a higher center and counseled for the possibility of early delivery. But this lady did not get admitted and got admitted after 2 days. So in spite of taking the tablet nifedipine retard, her BP was in the range of 168, 110. Again, they added tablet labetalol and put her on Maxel. Because they had anesthetists there at the sub-district hospital, they went ahead with cesarean section. 1.8 kg live female baby was delivered, and still, with labetalol, nifedipine retard, and Maxel, her blood pressure remained in the range of 140 to 80, 180 systolic and 100 to 110 diastolic. On second day, suddenly she started becoming breathless, restless, and she started having cough. Tachycardia, BP was 220 by 118 initially. Oxygen saturation was 70%, and the chest was full of wheeze. There were no clear breath sounds. So, Madam Hema, what is your differential diagnosis, and how would you go ahead with the management?
Good evening, everyone, and thank you, Dr. Sneha, for that very clear case presentation. Now this is day 2, 30 hours after C-section, and she has sudden cough and breathlessness. Her BP seems to be 220 over 118. So it doesn't look like they have done any aggressive management for the hypertension.
Right.
One of the most important dictums in management of hypertensive disorders of pregnancy is that the BP has to be aggressively brought down. She needed intravenous labetalol to bring down the BP. And the magnesium sulfate, fortunately, they have continued.
Yeah.
So, with such high BP,
at present, madam, what is your differential diagnosis for this catastrophe?
So it looks like since her oxygen saturation is less, pulse is high, it could be either a case of pulmonary embolism or a case of acute severe pulmonary edema. These are the two things that are coming to my mind.
Yes, yes.
So now we have to make sure that she gets out of this complication, right? So there is wheeze and the breath sounds are not clear. So this patient, it looks like she has to be immediately shifted to the ICU and she needs ventilatory support. So I would transfer her to the ICU. She should be intubated and put on ventilation. And the BP has to be aggressively brought down. So we have to start her on IV labetalol. And she probably needs an injection of Lasix if the possibility of pulmonary edema is to be considered. She can have a bedside, she can have a POCUS, point of care ultrasound, and we can see whether she has, we can have a look at her lungs.
Yeah.
So,
you have correctly pointed out, madam, it can be pulmonary embolism or edema. And then if you have a bedside X-ray, echo, and of course you have to go for the ABG and other investigation. But before doing all this, she has to be propped up and started with a high flow oxygenation, giving IV Lasix. You have rightly mentioned 40 milligram. And how much labetalol do you give, madam? How do you give labetalol? Intravenous.
We have to start an intravenous drip with labetalol. We can give an initial dose of labetalol of 20 milligrams. Wait for 15 minutes. If the BP doesn't come down, give her another 20. Again, wait for 15 minutes. Then go to 40. Like that, you can increase the dose of labetalol.
Yeah.
The maximum dose that you can give in a day is 200 milligrams.
Yes. So you can, depending upon the blood pressure, as you rightly said, you can start with 20 or 40 milligram as per the Parkland regime. But most of the obstetricians, they start with 40. Wait for 10 to 15 minutes. And if it is not coming down as per the expectation or prediction, you can increase the dosage to double, as rightly pointed out. Okay, so with all these drugs, even if this lady, of course, pulmonary edema is, you have collection of fluid in the interstitial space, stresses, so the lungs compliance goes down and there is hypoxemia and increased work of breathing. So definitely you have to follow this ABCD at the earliest and you have to manage this patient. So you have talked about the bedside investigations, X-ray, echo, and of course send the blood chemistry, the cardiac enzymes, the coagulation study, and of course you will start with loop diuretic as discussed, nebulizer, steroids, and assisted ventilation. So this lady was, given proper position, oxygenation, labetalol, and Lasix. In spite of that, and the mask oxygen was started. But before shifting to ICU, she went into cardiac arrest. Now, how do you manage this patient, Dr. Smita? I think we talked to Dr. Smita.
Good evening, ma'am. Good evening, everyone. So this patient, most probably this is a case of pulmonary edema because she is a non-hypertensive post-cesarean section. Most probably she had had a fluid overload which might have led to this condition. And in addition to that, she is having an acute severe hypertension which is not controlled properly with antihypertensives. Now that she has gone in for a cardiac arrest, she has to be intubated immediately and put on ventilatory support. And now that her BP, now that
the resuscitation, because she's
yes.
into yeah.
But one problem with pulmonary edema in severe preeclampsia is that when you give labetalol, there is a chance that it can aggravate pulmonary edema because it affects the cardiac function.
Right, exactly. So what is the ideal drug for this?
So the ideal drug is nitroglycerin drip infusion is best for this patient. So that you have to give initially 5 microgram bolus and then can be given at increasing doses, maximum up to 5 microgram bolus in first minute, and then every 30 minutes you can increase the dose, and the BP should be brought down slowly till it reaches about 140/90 millimeters of mercury. There should not be it should not be brought down very rapidly. That is one problem that has happened with this patient, I think.
Right.
And you also have to continue once the BP stabilized. We will have to continue with the once a spontaneous respiration has achieved, you can continue with diuretics. And if needed, if she is going in for hypotension continuously, vasopressors need to be added in this case.
Right. So fortunately, this patient was, managed with CPR and she was put on ventilator. She was revived within few minutes and, the blood pressure started rising to 100/64 and oxygen saturation also came up to 90% and then she improved subsequently. So I would ask you, Dr. Smita, for this case, right from the beginning, what all things went wrong and where? Was this catastrophe preventable? Because she was a registered case. So was this catastrophe preventable? If you can, tell us.
Yes, madam. This was a preventable condition. From initial onwards, the BP was not properly controlled, and after cesarean section.
If I can just interrupt you here. Is there a role of prediction for this case? Because if you go to the history, she was 36-year-old, infertile, obese.
Yes, yes, ma'am. She's elderly, obesity, and she had some impending features also. She had some abdominal pain, and we do not know about the renal function test and liver function test. If the RFT was initially abnormal, that would probably aggravate or probably predispose to this pulmonary edema. So all these are predisposing factors: elderly, obesity, severe preeclampsia, cesarean section, fluid overload. All this can predispose to pulmonary edema.
Yeah.
So
I would like to ask other panelists, do you want to add anything as far as the prediction part is concerned for this lady?
The first trimester itself, we can do the screening.
Yes, perfect.
Preeclampsia.
Perfect.
If it is more riskier, we
Mhm.
can give aspirin 150
Right.
daily to prevent the condition.
This
And
patient would
also,
definitely
after
get aspirin.
even she's getting that treatment, after
So So first
6th
and
month
foremost,
onwards.
we could have predicted this. And
Yes.
prediction, because the maternal characteristics are they're very suggestive. Elderly, obese, and infertile lady. She conceived with IUI. So all these maternal characteristics, if you use the SDB gestosis score also, she comes under high risk category. So low dose aspirin and high dose calcium could have been used right from the beginning. That is one. Secondly, anything on biophysical or biochemical test, if anybody wants to add, please. Ultrasound, do you do ultrasound early at
Yes.
11 to 13 weeks?
Yes, 11 to 13 weeks ultrasound where you look for the uterine artery pulsatility index
Perfect.
and
Yes.
also the SFLT to VEGF
VLGF and
ratio can
SFLT.
also be
Yes.
that
So,
also can be checked for.
yes.
These are
So,
predictors.
very good. So that comes in prediction, which we have missed right from early pregnancy. She was under the care of obstetrician. So she should have predicted first and foremost that with the biophysical and biochemical test, along with the maternal characteristic, if you combine, the prediction is almost to the tune of 95 to 100%, right? So we could have done this prevention aspect. Then when she basically, whenever you have high risk patient, you should not tell the lady that everything is fine. Okay, she was informed that all the investigations are normal, and that is why you have to tell her that you are a high risk woman. This pregnancy is high risk, and you have to be in continuous surveillance. How do you triage at 11 to 13 weeks? When you do this uterine artery pulsatility index and all this scoring, if you find that lady is at high risk, she needs every visit, she needs specific investigations and individualized care. Okay, so our patient was high risk and she was missed. Next, any other point? When she reported first, what was her blood pressure and what should have been the treatment there?
Admission and control of BP.
Yes. So 176 by 116, what should have been the drug of choice that time?
At that time, labetalol should have been started.
Yes, and any other, suppose she was at periphery, she was at PHC. Dr. Joshi, please unmute yourself. Please unmute.
Okay.
Yes,
Yeah.
please.
If it's in the periphery, you can give Nicardia also, oral Nicardia.
Nicardia.
That is one option.
She has received tablet nifedipine retard. Was that the right drug?
Nifedipine.
No.
Yes.
So
What was the
capsule-
right drug? Not retard, because it was a severe hypertension. She can receive two drugs, either injectable labetalol or oral capsule nifedipine. Okay, the orange color capsule, because that is a fast acting, right? So severe hypertension, she should have received capsule nifedipine, 10 milligram. Okay, and then this patient should have been shifted properly to the higher center. And then when she got admitted to the higher center, again they just added tablet labetalol. So at both the places, you have to see what were all the delays. It was because of the lack of knowledge initially, and then of course in the transport also there is a delay, and delay in the management also. So whenever you have a patient with severe hypertension, she has to receive either intravenous labetalol or oral capsule nifedipine 10 milligram. Right. So this patient, as you have already said, also when she is posted for cesarean section, can anybody tell me what mistake we have done here? What is the usual anesthesia we are using?
Generally, we would be giving spinal anesthesia. But
Right.
since this patient is a very high risk, a GA would have been better for her.
She was operated under regional anesthesia. That is what we, and usually we do it under regional anesthesia. But then what do? We do preload. Okay. So this patient already who is having overload, fluid overload, she had received preload. That is a very fast infusion, right? So we could have avoided this. And then of course, after the baby is delivered, whenever we are trying to give any oxytocin, that time also we have to take care that we should not give methergine, which actually, raises the blood pressure, and also it squeezes. And during the third stage, there is a increased venous return, increased load on the heart. So all these things should have been analyzed and managed properly. Such a simple case who is known to be high risk, if she would have been, predicted, given preventive measures as aspirin and calcium, managed at the very first point of contact when she had hypertension properly, this may not have been the scenario. So this is how we have, missed this. Okay. So thank you so much. Once again, we go ahead with Dr. Hari
And
Prasad.
madam, one more thing.
Yes, please.
Postoperatively, this patient should be given thromboprophylaxis because
Yes.
she is at high risk of thromboembolism even later.
Right. And also she needs to be monitored continuously for first 72 hours at least, right? Once she is operated, I said that at SDH, Sub-District Hospital, just because they have anesthetists, they went for cesarean section. But they did not know the proper post-op care of this patient also. And also the fluid, they have to manage this fluid therapy also properly. So all these things, she was mismanaged at every stage. Okay. So we go ahead. Thank you, madam, for your inputs. We go ahead with the next case now. We have this 20-year-old primary gravida. She comes to you with 9 months amenorrhea. And she's referred to the tertiary care center at 11 p.m. at night from a nearby nursing home. So she was there in the nursing home for around 8 hours, and she was in labor for another 4 hours before admission, right? So almost 12 hours of labor pains. So as there was no progress, she was, they decided to go for cesarean section. When the sister tried to catheterize bladder, there was no urine output, absolutely. And on further inquiry, they found that even after those, over those 8 to 10 hours, she was not having any urine output. She did not pass urine. So she was referred to tertiary care center. When on examination, she was having tachycardia, blood pressure is 110/70. Uterine contractions were very, very severe in intensity. They were frequent. There was no relaxation in between. Fetal heart was between 100 to 120 minutes. And even with so much of long duration, cervix was only 3 centimeter dilated, membrane substation 0, and there were altered bleeding. What do you feel is the diagnosis? Yeah, I give you further, few investigations that her hemoglobin was 8 gram%, platelet was 1 lakh, PTINR was 2, and APTT was prolonged. Fibrinogen degradation products were present, and fibrinogen was only 150. So what is your diagnosis, Dr. Hari Prasad, sir? And how do you manage this case?
It's a case of abruptio placenta.
Right.
Actually, initial stage, the patient is, it is a clinical diagnosis actually.
That is why we have put this separately. This is
Yeah.
a clinical diagnosis. Placenta.
Clinical diagnosis. The
Yeah.
typical presentation will be, the uterus will be tense and tender.
Yeah, it is.
When you palpate the abdomen, we can diagnose,
Yeah.
actually. And the patient will be confused somewhat. And
Yeah, so she has abruptio placentae. Yeah, she has abruptio placentae, but when we sent her investigation, this is the picture. So what is it suggestive of?
Already she had coagulation failure.
Right. Now, how do you manage this case? Whether she, it's already, you can see here, she is, in spite of having abruption, there is no progress of labor. Usually we say, in case of abruptio, the patient progresses very fast. There's lots of myometrial irritation also. But here, there's no progress of labor. And the fetal distress, you can see the fetal heart is only 100 to 120. So would you like to take her for cesarean section immediately? Because once the placenta separates completely, the baby will die.
Yeah.
So how do you
We
go
have
ahead?
to correct the coagulation failure along with cesarean section.
Yes. But then how do you explain the relatives and what consent do you take for this patient?
High risk consent, because sometimes if there is coagulation failure, it will be difficult. There will be bleeding, and sometimes hysterectomy may be required.
Right. So, anybody else wants to add anything? Dr. Joshi, Dr. Hema?
She may she should have intensive care unit, intraoperatively, post-operative treatment. Massive transfusion protocol should be
Right.
initiated at the beginning of the procedure.
Right. Everything
At
is
risk of
accepted.
hysterectomy.
Only my question is, she's having fetal distress. So should we take her for a cesarean section immediately? Or otherwise, if the whole placenta separates, then, already 100, 120. So it will be, now it is fetal distress, the baby can die.
You can
She should be given blood and blood products, and simultaneously we should take
take
her up
for
for section.
Right. So it's not one after the other, but then yes, you're right that you have to arrange for blood and blood components and simultaneously arrange for the operative procedure.
operative.
But then how do you explain the relatives? Because they will say now the baby is alive. Sometimes if it happens that, over a period of maybe just 15, 20 minutes or half an hour, there's no fetal heart sounds. Then how do you explain and what informed consent do you take for this patient particularly? What I'm
Because
trying to say,
stillbirth.
yes, please go ahead.
Since it is a case of abruptio placenta,
Mm-hmm.
Anytime baby may die in utero.
Yes,
So
basically,
a stillbirth also we should tell to the bystanders.
Closer. Dr. George, do you want to add anything?
We have other than fetal death, this uterus might not contract. It may go for a woody uterus. So she might bleed profusely and she might require a transfer to a higher center. This is a nursing home.
This
So
is
she
a
might,
tertiary care center now. She has come to a tertiary care center. Okay.
She has to be taken into a ITU after surgery. Thing is that she might go in for a coagulopathy after this, and
She's already. See, all of you are, adding points to this management. But what I'm trying to tell you is that when the patient comes to your tertiary care center, you have to tell them that the patient has come to you in this condition, and if at all you have fetal distress, and if you try and go for cesarean section right away, then you may be able to save the baby, but you may lose the mother because she is into coagulation failure. So unless we correct the coagulation failure, it will be dangerous to take her for cesarean section. So, you are trying to save the baby, but you may lose the mother. So that's the thing you have to explain them properly and take it into informed written consent that you have to arrange for blood and blood products simultaneously, try to infuse some and then go for cesarean section. In that case, you may lose the baby, but the mother will be safe. You have to be safe for yourself, right?
Yes.
Do you agree to this?
Yes.
So I think that has to be done concurrently, no?
That is what
Simultaneously,
everything has to be done simultaneously. That is what I'm trying to say, that everything has to be done simultaneously, but then you have to take an informed consent that we are trying our best to, stabilize the mother, get the blood and product. We're trying to get it operated at the earliest, but we have to make the mother safe, and then we should go for cesarean section. It's everything going on simultaneously. Still, even if there is a delay of 10 to 15 minutes, and if at all you lose the baby, it may reflect badly on you. That is why there's a role for informed written consent as far as the baby's outcome is concerned. Now, how do you go ahead and what all blood components do you want to, what are the, I have given you the list of investigation. So what are the blood components you want to infuse for this patient or transfuse?
Concentrate, RBC concentrate, cryo, and fresh frozen plasma.
Okay.
Platelets. All these things are necessary.
Platelets, she's having 1 lakh already. So
then cryo will do. Cryo.
Yeah. Cryoprecipitate and FFP.
FFP
Yes.
and
I think for her, fibrinogen seems to be near normal. The APTT is strong, so better would be FFP for her.
Yes.
And platelets, unless it is less than 775,000, we need in, this is around 1 lakh. So we wouldn't really go for, because if she's in coagulopathy, adding all these is adding fuel to fire.
Yes.
So I think we should use something like a thromboelastography, or in a tertiary center it is available. So either a rotom or thromboelastography has to be used to think of what to be given.
Right. So as per the recommendation, when the platelet count goes below 50,000, then only we have to think about the platelet concentrate. Till then, we don't have to worry about it. But definitely, the fibrinogen is on the lower side. Fibrinogen is on the lower side because she is bleeding and FDP is present. So we have to stop this process of DIC, right? So FFP is the best. And how much FFP do you require for this patient? How do you calculate? Dr. Noori, if you can take up this, please.
Yeah, the ratio is 1.5 for every 1.5 pack of pack cell, we give 1 FFP. So if we are giving 2 or 3 pack cells, we have to give 2 FFP.
Okay. And how do you calculate how much, how many packs do you require? As per the weight of the patient. Suppose this patient's weight is 60 kg. Then how do you calculate? 20 into 60, the weight, that is how 1200. Each pack is 240. So around 5 packs of FFP you require to get this, level of fibrinogen. Cryoprecipitate, anybody wants to make a comment on this?
Cryoprecipitate has to be given when the fibrinogen levels are less than 1 gram. So cryoprecipitate up to 10 units, that is 5 units at a time, and twice can be given even without waiting for the coagulation profile to come. So 10 CP can be given directly, actually, before waiting for even the coagulation if she is having ongoing bleeding.
Yes, meanwhile you monitor with all the coagulation profile, but it is usually the 5 packs of FFP and of course the cryoprecipitate, and then you continue to monitor with whatever blood and blood component you are transmitting to the patient. First, you have to see that the hypovolemia is corrected. This patient, if you remember initially, this patient is not only having abruptio placentae, but she is into hypovolemia and oligonuria, right? She is into anuria. So that because of hypovolemia, there is decreased glomerular GFR, that is glomerular filtration rate. So she is into acute tubular necrosis. Yeah, so you have to correct the hypovolemia first. So that is why you have to give the transfusions, whatever blood component is available. So may it be packed cell, may it be even whole blood, because she is at present into hypovolemia. So correct hypovolemia and then correct the hematocrit and coagulation structures as well, so that your GFR is improved.
ढकना तो पड़ेगा ही ना, बारिश आ रही है तो।
Can we mute?
तो बताओ ना ये चीज तुम उनको कहाँ बता रहे हो?
Yeah. So it improves the GFR so that the patient
बाद में
doesn't
बोला
go
तुमने।
into irreversible renal failure, or what we call it as acute cortical necrosis, right? So we have to take care of the labor delivery as well as coagulation failure, the anuria, complications of abruptio, because she's already going into DIC, and of course she may land up into fetal distress. So we have to manage all this simultaneously. We have to manage this at the earliest and see that we go for operative procedures safely, deliver the baby. And as you have rightly pointed out, that we have to be very much conscious about the postpartum hemorrhage, so that is why we have to be use very effective oxytocin. So what is the most effective oxytocin at present you are using as a prophylaxis? Anybody can take up. This is an open question. Dr. Hema?
Yeah, we are giving oxytocin actually. We are following the protocol of active management of labor. That
Right.
is popularized by our association, KFO.
Yes.
So it is a rule of 5, 5, 5, 10, and 20.
Mm-hmm.
So 5 units of oxytocin is to be given over a period of 5 seconds.
Okay.
Immediately, 5 units intramuscularly, 5 units intravenously, 10 units intramuscularly.
Right.
And then
That-
20 units are to be added to the drip and to be given over 2 hours.
Yes.
So,
So it's a concentrated oxytocin infusion.
yes,
is what
5
we-
units intravenously and 10 units intramuscularly immediately, and then followed by a drip.
You're right. You're
Or
right.
alternatively, you can give carbitocin.
Yes. Perfect.
If
That
you're
is what I
giving
was coming.
carbitocin, your oxytocin is not going to work because they have the same receptor.
Yes.
So you can give either of them.
So that is what I was trying to say. When you have a high risk patient who is very prone for PPH, better to prefer for carbetocin, because carbetocin single dose is equivalent to, or it will work for 16 hours, right? And it is very, very effective. Of course, if you can, if the carbetocin doesn't work, maybe later on you can go ahead with methergine. But then as a routine, what you are preferring, I think concentrated infusion of oxytocin, that should be good enough. So that is about the case that we have managed the hypovolemia. You are giving blood and blood components, managing the hypovolemia, improving the hematocrit, also improving the coagulation failure. The clotting factors are being improved, and simultaneously you are stabilizing the mother and operating, taking care of the PPH. So I think we have managed the case well. We move on to the next case now, Dr. Shajna. This is for you. I think this we can take it as a last case if you're done with it. 32-year-old para 1 previous seizure. She's got male child, 1 year old. Now she came to you as bleeding PV. Yeah, this is her first visit to your hospital during 6 months because she's transferred from somewhere because of the husband's job transfer. So after reaching the hospital, the bleeding is stopped, and when you examine, you ask her the history. She gives you history of spotting during early pregnancy. When you do the scan, you find the placenta is low lying, and there is absent RP leg, excessive vascularity in the lower segment, and laminar flow. So anomaly scan is normal, no abnormality detected. So this lady at 30 weeks, she reported to you with severe, significant bleeding at home, and by the time she reached the hospital, she collapsed. So what is the diagnosis? How do you manage this patient? Dr. Shashna. Do we have Dr. Shajna? Okay, so I think Dr. Nuri, we can start from you.
Okay, this is a case of antepartum hemorrhage, and she has a low-lying placenta. So this patient has come in shock because she has collapsed, and so we have to aggressively manage her with fluids and resuscitate her. And along with that, we should send the investigations like complete blood count, blood groupings, blood for cross matching. And
Hello.
Yes.
Ma'am, sorry, ma'am. Actually, network got disconnected. I'm very sorry.
Who's that? Dr. Shajna?
Shazna, ma'am.
Yeah. So, Dr. Shajna, please go ahead. This is your case to be discussed.
Okay, ma'am.
Do you want me to read it out? Do you want me to read it out? This is a case of previous section
No,
with
ma'am. No.
APH
I have read that.
with absent.
Okay, ma'am. So this.
Yeah. Please
No,
go
ma'am.
ahead.
It's fine. Okay.
Yeah.
Okay, ma'am. So this is a case of placenta previa, and it's in ultrasound with beta spectrum, and this patient has come to us actually for the first visit. So initially, what we have to do is
When she
initially she
has
had a
collapsed, this
sentinel
is the
bleed.
second visit. This is the second visit.
Okay, okay. Initially, she had a sentinel bleed or warning hemorrhage was there, but it had settled. So this is the second episode of APH.
Yeah.
So what we have to do is initially we probably will have a blood group and RH typing and a baseline
CBC because she has come to us before. This is
She
her
has
second visit.
collapsed. Yeah, yeah.
Okay,
So how
so
do you manage this patient?
okay. So initially put a whiteboard cannula, 2 whiteboard cannulas, and then start aggressive resuscitation. So ensure her airway, breathing, and then circulation. So
Yeah.
start her on IV fluids. So
Yeah.
and then simultaneously we have to take a high risk consent because she has already been collapsed. So at least we can personally counsel the bystanders or because she has already been collapsed and
What
she
will
has
you counsel for? What all things?
counseling is because since it was the placenta accreta spectrum.
Yeah.
And baby maturity is also a question. So it's only 30
For
weeks period
mother,
of
for
gestation.
baby, what all things you will say? For
So as for the mother, there are we have to do an immediate emergency cesarean section. So and since it's
yes,
an accreta spectrum, there is all chances for aggressive massive transfusion will be required.
right.
And we have to counsel them for peripartum hysterectomy. And then we have to counsel there is there are chances that she can be in ICU have an ICU admission for a long time and to them consumptive coagulopathy is possible. And
Okay.
then
It's all
one,
these things
one
you
more
have
thing is
taken as informed written consent before operative procedure, right?
yes, ma'am.
What about the
Yes,
baby?
ma'am.
How will you counsel 30 weeks? The
So
baby.
fetal maturity is we have to counsel that at least lung maturity takes 32 to 34 weeks, but we can't risk the life of the mother because we can't wait for the fetal maturity. We can't wait till 32 weeks or 34 weeks. We need an immediate management. So
Yes.
our first concern is since the mother, we don't have a we will tell them that our it's a tertiary care ICU, NICU.
Yeah.
So we'll try our maximum. At least the baby will be approximately more than 1.5. So there is chances that the baby can do well.
Yeah.
So, but we can't wait for the sake of the fetal maturity
Yeah. So
that
even
we'll
if we
counsel.
do cesarean section, we cannot assure the survival. Yes.
Yes, ma'am. Then so we we have to take consent, including peripartum hysterectomy.
Yeah.
Increase the chances of morbidity and mortality also should be explained. And after and then we have since we have a blood group and RH typing, arrange for blood PR both packed red blood cells, FFP.
Right.
And then a proper anesthesia, everything should be well equipped because we'll be most probably we will have to do a peripartum hysterectomy.
Right. So, Dr. Joshi, before you go for
Yes.
this operative procedure, what special precautions do you want to take, and whom all do you want in your team before going for operative procedures?
I mean, I would like a most experienced anesthetist physically present in the theater.
Yes.
I would like to alert the blood bank for massive. We alert for massive transfusion protocol. If there is a code system like what we have, we would escalate code 5 or MTP and code 1 for maternal collapse. So all these teams will come together, and it is important to keep in mind that we should have the RRT team because she can arrest at any time. She can have a cardiac arrest, so rapid response team from the ICU should be able to start the CPR. So all the resuscitative measures should go hand in hand and simultaneously. You cannot go from one over to another.
Right.
This would be the preoperative. Obviously, consent has been already mentioned.
Yeah.
And shall I go on to the intraoperative?
Yeah. So, what special precautions during the procedure? So, I'm
During
sorry.
the procedure,
I did ask you whom all do you want in your team? In addition to, you are a senior obstetrician, you want a senior anesthetist, neonatologist, of course, and blood bank, as you said. In addition to these 4, do you want anybody in your team?
Madam, an interventional radiologist would be a good idea.
Yes, and
urology.
Urologist.
Some neurosurgeon, oncosurgeon, or maybe even a general surgeon, right? Why do you need them?
Yeah, I mean, in
Why do
case
you need?
we, if there is a bladder involvement, and if we want to fix the bladder or do excision of the bladder, you might need a urologist.
Yeah.
But if you
You
are
have a
experienced in
Percreta
Akkrita surgery,
top. Yes,
yeah,
definitely.
you should anticipate Percreta. And even if you are an experienced obstetrician, I would prefer that you have a second senior obstetrician, both of them on either side of the table, which might be sometimes more beneficial than having other specialists.
Right.
This is an emergency scenario, so we put a vertical incision.
Now you can talk about the incision, right, from abdominal incision and the uterine incision, and then how do you go ahead with the placental removal?
Yes. Before that, I would prefer that it's a general anesthesia, not a regional anesthesia.
Right.
Okay, she is at risk of hypotension. And the abdomen should, when we insert the Foley's catheter, we make sure that the catheter bulb is pushed right up so that it reaches the top of the bladder. And then we clean and drape up to the sternum, and the vertical incision from the from the pubic symphysis up to 3 to 4 centimeters above the umbilicus. We should not hesitate to extend the incision upwards. It should be liberal. And when we make the incision, we have placenta percreta at the back of the mind, and then once we make the incision, we have to anticipate the possibility of any adhesions of the bladder to the anterior abdominal wall. So we should not allow any bleeding to start before we make the uterine incision. Once you have reached the uterus, obviously the incision should be on the top of the uterus. It can be in the upper segment, it can be transverse or vertical, but it should be above the level of placenta. So upper incision, and then once you deliver the baby, you immediately get the ankles with green Amitage, arrest the bleeding, and do not touch the placenta. Assuming it's a placenta, Akkrita, Percreta, whatever, then immediately move the uterus caudally towards the foot end, and then straight go for the aorta clamp. I'm sure all of you are familiar. Paini sir has been, this is internationally published. Aorta clamp, no dissection, pal. You pack the large bowel to the left, pack the small bowel to the right, and then your incision, as I said, is well above the umbilicus. So it should be vertically down. It should not be you should not struggle to get the clamp on the aorta. It should be very easy, perpendicular, straight on the aorta, above the bifurcation. You first pick up with the Babcocks and then clamp the aorta, and make sure the tip of the clamp goes beyond the aorta, and palpate both common iliacs. Make sure this brewing, the pulsation has stopped. And then we decide what we are going to do. I would, with my experience, go for an obstetric hysterectomy rather than a conservative procedure. We get into trouble if you go for conservatism, because she has already lost at least 1 or 2 liters. We're talking about cardiac arrest. So let's go clamp cut. And then once you reach the uterine vessels, if you have plus bladder in front, then you have to be careful. You start using the bipolar and the monopolar, and there is a coagulum between the bladder and the placenta, and then coagulate and cut. And you don't worry about damaging the bladder, because you don't worry about, at the same time, very often it's possible to separate the bladder in that scenario. And then you don't aim for a total hysterectomy. Our aim is to get below the level of the placenta, which may mean somewhere into the cervical canal, but you should be certain that we have got the complete placenta. Once the hysterectomy part is over, you can release the aorta clamp. Somebody should have recorded the time, duration for which the aorta clamp is on. You should have told the anesthetist that we are applying the aorta clamp, and then you release, alert the anesthetist, release the clamp, and see whether there is any bleeding from the bladder base. Occasionally you might get, if at all you find bleeding, clamp again, and then go for internal iliacs.
Right.
Sometimes it might be prudent to go for internal iliacs and then put a wide bore drain into the peritoneal cavity before you actually
Right.
come out.
So that is very much in depth and very, very point wise. You have, said it all. But suppose now this lady is a young lady and, she's 30 weeks, the baby is not fine. And now that she is stabilized with all your blood product and, and at present she's not bleeding actively. She has not given you the consent for hysterectomy and trying to go for the conservative procedure. So how would you go ahead with what uterine conservative surgery you would prefer?
I mean, you can go for local excision of the placenta, but the risk is high. There is a skill shortage of conservative surgery, certainly in Kerala. I don't feel comfortable myself going for conservatism, especially when she has already lost. So it is a tricky situation. There is a dilemma there. I would ask a second opinion for somebody over the phone.
Right. So I think yes, you're right. For this patient, definitely who was collapsed, you have to go for rather plan for obstetric hysterectomy, and then of course don't fumble at all. But then yes, if at all this is a case where there is a dilemma, you have to take an informed written consent that in spite of everything, trying everything, if at all it doesn't succeed or maybe she bleeds or worsens, we have to go for obstetric hysterectomy. But there is what is called as triple P procedure where you do the placental mapping where you have patchy adherence. So there you can go for the stepwise devascularization, and then you can go ahead with the myometrial patchy resection, and then you close the myometrial patches. That is how you can go ahead. Nowadays there is one more procedure what is called as the Comog MG stitch, where you do the stitch through through and through from both sides. Occlude the uterine arteries completely from both sides. Of course, you have already applied the aortic clamp, so you don't have to worry about it. But then once you make the uterus totally avascular, you can just scrape it out, the placenta. That is what people are doing it quite regularly nowadays. They have centers even in Gujarat, and this is a patented stitch. I said Comog MG stitch. So people are trying to get accustomed to this technique. So maybe in few days, maybe we all will be familiar and well versed with this situation or this technique, I think. So we have already talked about coagulopathy, so we will not discuss the coagulopathy once again. Definitely all these are the theoretical aspects. All of you know this better. So I will not discuss this. Only one question to Dr. Noori. We have discussed all this. So Dr. Geeta has already participated in the discussion. I just ask you whether this catastrophe was preventable because she has come to you in 6 months. She has given you history of early pregnancy hemorrhage, warning hemorrhage. So was this condition preventable? Whether there was any role of prophylactic or tightening or tocolytics, and what precautions should have been advised by the obstetrician?
Okay, since she has already come once with warning hemorrhage, we should have taken precautions like correcting her anemia, arranging, we have to counsel her properly that the next time she bleeds, the bleed may be more, and she may have, she may require emergency cesarean section at any point. So we have to counsel about prematurity, about need for blood transfusion, about having enough.
What precautions? Whether you would like to see, it is a case of placenta previa accreta, whether you should have hospitalized her, whether the obstetrician should have hospitalized her.
Yeah, when she has had her first bleeding, it was better to have hospitalized her and given her a course of steroids for accelerating the lung maturity, and also to see that she has no further episodes of bleeding.
So for that,
and
what
there is no role
she should not have intercourse, internal
she should avoid travel, take adequate rest. There should not be any sexual intercourse should be restricted. And there is no role for prophylactic os tightening as such in
that is what
placenta previa. But if she has any, Yeah, if there is any history of any cervical incompetence in the early scans only, otherwise for placenta previa per se, there is no role for prophylactic cause
What
tightening.
about
And
tocolysis?
tocolysis also not to prevent preterm labor, but to give a course of steroids, we can give tocolysis.
But when she
Otherwise,
doesn't have contractions, why do we want to give
yeah, there
tocolysis?
is no need. Yes, yes.
Yeah. So these
Otherwise,
are
completely we don't give
empirical measures.
tocolysis.
These are all empirical measures. It doesn't have any rule as far as the evidence goes. So only the precautions for pelvic rest, not to have intercourse and internal examination, and preferably she should be hospitalized with all these problems discussed with the family, and blood products arranged or reserved for her, right? And she can go to any. I think we just I don't think we should take up this case. I think what do you suggest? Can we finish up this case?
It's already 9, I think, madam.
Yeah, that is what I'm saying. So I think we should stop with this panel discussions. There are many interesting cases, but I would just wind up and I would the last case only I will say that it was a case of diabetic ketoacidosis who presented at term she was diagnosed when she developed diabetic ketoacidosis, and the simple thing missed was going for the OGCT. She was not diagnosed as a case of JTM. Okay. So that is what was the last case. So the message here is very clear that we should go for universal screening, that is screen every woman during every pregnancy, that can avoid the catastrophes or the near miss situations. So I think anybody has anything to make a comment here, the forum is open. I just take this opportunity to thank all of you and just make an humble appeal to all of you. I'm contesting for Vice President Foxy from West Zone. Friends, you know that I have worked as a National Committee Chairperson for Foxy Breast Committee, and I was a ICOG Governing Council member. So all of you have, I'm sure majority of you have witnessed my work. I'm still working hard as far as the academics and organizational activities concerned. I'm a hardcore academician, and of course, I'm working for the community as well. So I seek your blessings and wholehearted support and your votes for me during my elections in August. Thank you so much. Over to you.
Thank you so much, madam, for that enlightening panel to madam as well as the whole panelists. And our supports and wishes from the whole KFOG team and Pogs for your candidature for Vice President Foxy of West Zone. Our full support is there, madam. And
thank you so much. I thank all my esteemed panelists for their very valuable inputs to each and every case. I'm very happy to see all those seniors who are experienced and added value to this discussion. Thank you so much.
Yes, Sujitra ma'am, our KFOG, Sujitra ma'am, do you have anything to add on to this? I think ma'am is not available. Dr.
I'm here.
Ma'am is there. Okay, ma'am. Do you have anything more to add on to near miss?
Not really. It was very nice. All the case scenarios were excellently presented. And we got a lot of information because day to day we are dealing with such cases. So thanks a lot to Dr. Sneha and all the panelists for their wonderful interaction. It was very enlightening. And all the best, madam.
Thank you so much. Thank you, Dr. Hariprasad, Dr. Joshi, Dr. Geeta, Dr. Hema, Dr. Nuri, Dr. Smita. Thank you all the panelists, and thank you everybody from KFOG. Thank you all the delegates who have joined. I can see Dr. Hemprabha Gupta from Lucknow. There are many people who have joined, from other states also. So thank you so much for your support, and we continue with the academic discussions here onwards. Thank you so much. Thank you. My special thanks to Dr. Mumtaz, who have really taken pains to organize this event. Thank you so much.
Because of an emergency case, she had to leave, madam. She asked to
inform.
All
the best, Dr. Sneha. Best of luck, and we are support. We are with you to support you.
Thank you, madam. Thank you so much. Thank you.
Okay.
Good night. Good night.
Okay. Thank you so much to all of the leaders here and our KFOG presidents, dear Sujitra Sudhir madam, Sneha Bhoyar ma'am, Kunjumuddin sir, and the upcoming President Fesi Louis sir, and Dr. Kiran Kurkoti, and all the panelists, Dr. Shasna Hariprasad, Noori Khalid, Dr. Smita Dikoth, Hema Warrior, Dr. Geeta Epi, Dr. Joshi, and Dr. George Joy Irali. And thank you so much. And we expect more from you in further sessions. And thank you so much, and good night to all of you.
Good night.
Thank you
Good
so
night.
much. Thank you. Good night. Bye. Bye.
Bye.